Probably not. I'll teach something too. Okay, you want me to get started?
Yeah, let's do it.
Okay, cool. So I think I'm going to talk about seizures today. Seizures are defined as any transient, usually it is transient, motor sensory uh, phenomena that is produced by abnormal, excessive, synchronous discharges in the brain. So basically, it's an electrical phenomena, so to say. Stroke is usually a vascular phenomena. So seizures are defined as any transient motor sensory. It can be autonomic too sometimes, psychic. Any transient, basically neurological phenomena that is produced by abnormal, excessive, synchronous discharges in the brain. Seizures can be provoked or they may be unprovoked. These are very important terms to understand when we define epilepsy and the difference between seizures and epilepsy. So when it comes to the definition of epilepsy or in the context of seizures, provoked seizures usually imply seizures that are, so to say, induced by usually systemic causes such as, metabolic problems, toxic problems. Um, Usually the metabolic problems are, sodium abnormalities, calcium abnormalities, magnesium abnormalities. Potassium abnormalities usually does not cause or result in provoked seizures. And of course, glucose regulation problem, hypo or hyperglycemia, can induce seizures. Toxic causes usually are drugs of abuse, mostly stimulants like cocaine, amphetamines, although THC has been shown in some animal models, and I think even human case reports that THC can lower seizure threshold. CBD is actually protective. Or alcohol. Too much consumption of alcohol um, can result in seizures, but usually it is alcohol withdrawal that will result in seizures. So toxic causes. Then there are like just drugs, prescription drugs that may reduce your seizure threshold. Some of the most common ones that we see are antibiotics that we use in the hospital. Usually cephalosporins, cefepime especially, um, and in the setting of renal failure, uh, can lower seizure threshold. Um, Fluoroquinolones, and then your imipenem and meropenems can lower your seizure threshold. Bupropion or Wellbutrin can reduce your seizure threshold. And toxicity of certain drugs. I mean, there are so many drugs like overdose of, including seizure medication. If you like consume 50 tablets of Dilantin, it may actually cause seizures. So toxicity of lithium, for example, baclofen, Dilantin, um, can cause seizures. SSRIs, usually seen in patients who try to commit suicidal attempts by overconsumption of drugs. Sleep deprivation is thought, to result in seizures in some patients. Some would like to consider that as a provoked cause. Um, However, patients who are epileptic, they may also have seizures because of sleep deprivation. So you have to be careful when you say that. What is often confused is neurological etiologies, such as a brain tumor, for example, or let's say, for example, a stroke, an ischemic or a hemorrhagic stroke. or a TBI. We often like to say that, okay, these are provoked from these etiologies. So when I say definition of provoked and unprovoked, it's very important to remember that provoked causes usually imply uh, systemic causes like metabolic toxic problems, or due to drugs. Neurological etiologies do not count as provoked causes. For example, once the TBI has occurred and patient has suffered from a brain damage, you cannot necessarily reverse it. The same thing with strokes, or for example, tumors. So tumor, yes, you can remove some of the tumors. Some of the tumors you may not remove, but sometimes even if you remove the tumors, it's not necessarily the brain, like the brain tissue next to the tumor that may be producing seizures. The brain tissue that may be producing seizures may be distant or remote from the tumor. So brain or neurological causes usually are not included as under the provoked category. It usually refers to the systemic problems, which you would hope that you fix them and patients will not have recurrent seizures. For example, you fix somebody's hypoglycemia and then you maintain normal glycemia, you would assume that patients will not keep having seizures. Or you stop certain medications and then you would expect that patients will not have seizures. So that's why provoked causes are something that may be reversible, but those neurological etiologies and the damage that you sustain from them, you cannot fix them, you cannot reverse those damage. So almost always neurological etiologies are considered as unprovoked seizures. So if you don't have any of these, then you have an unprovoked seizure. That is the first question you should almost always try to answer in any new onset seizure patient, whether the seizure was provoked or unprovoked. And the reason is that, which then brings me to the definition of epilepsy. Epilepsy is defined as two or more unprovoked seizures which are separated by 24 hours or 24 hours apart. Two or more unprovoked seizures separated by 24 hours. Why did they decide to choose like two? Why not one? Why not three? I mean, did they just randomly come up with the number? It was actually studied in, I think, two big studies from UK, probably more than 2 decades ago. I think the first group and UK mass trial, which eventually it boils down to the risk of recurrence. So for example, if patient has one unprovoked seizure, the chances of them having a second unprovoked seizure over next 2 years was average close to 40%. Okay. However, if they have two unprovoked seizures, the risk of having a third one over next 2 years was close to 73%. If they have three unprovoked seizures, the risk of having a fourth one was close to 76%. So the risk increases significantly from here to here, not so much from here to here. So that is why they decided to choose number two. And anything more than 60% recurrence risk is considered a high risk. In other words, you can consider them epileptic. So that is where number two comes from. Two or more unprovoked seizures 24 hours apart. Around 2014, I believe. So this is the first definition, or A. The second definition, B. Around 2014, ILAE, or International League Against Epilepsy, um, came up with another definition, or a newer definition of epilepsy on top of the first definition, which still holds true, is that you can consider somebody epileptic even after one unprovoked seizure if you can determine that the risk of recurrence is more than or equal to 60%, which is considered high risk, over next 10 years. Okay, now how can you determine that? How can you determine somebody's risk is more than 60% after one unprovoked seizure? So there are a few things. One, some of them are just the causes, or the some of the causes of seizures will just put you at a higher risk of recurrence even after a first unprovoked seizure. So the three main causes that will put you at a higher risk of recurrence are history of stroke. So for example, patient had a left MCS stroke, let's say 2 years ago, and now 2 years later after the stroke, they present with a focal seizure. So when stroke is the etiology of the unprovoked seizure, the recurrence risk is more than 60% even after first seizure. So they are considered epileptic at that point, even after the first unprovoked seizure. The second one is history of CNS infections, so meningitis, encephalitis, even abscesses, and then history of moderate to severe TBI, moderate to severe TBI. On a side note, mild TBI actually is associated with increased risk of PNES or psychogenic non-epileptic. I don't like to use the word seizures because seizures by itself means abnormal synchronous excessive discharges in the brain, but PNES patients don't have that. So although the terminology is seizures, I just use word spells, psychogenic non-epileptic spells, layman term for which is pseudo seizures. Mild TBI is associated with increased risk of PNES. However, moderate to severe TBI is associated with increased risk of epileptic seizures. And if you just want to know a little bit more, when it comes to the recurrence risk for TBI, that for seizures, it is actually classified based on the duration of loss of consciousness. So mild TBI, the duration of loss of consciousness is usually less than 30 minutes. Moderate is 30 minutes to 24 hours. And this is more than or equal to 24 hours when it comes to the recurrence risk for seizures, okay? So mild TBI may be associated with slightly increased risk of PNES, although they may also have epileptic seizures. But moderate to severe TBI, and the other two uh, are actually part of the diagnostic workup. If somebody has an abnormal EEG after the first unprovoked seizure showing epileptiform discharges, and then abnormal neuroimaging or an abnormal CT scan or basically MRI. Let's say somebody has an unprovoked seizure and you do an MRI and patient has a tumor in the brain. So the recurrence risk for tumor is not very well known, like stroke, CNS infection, and moderate to severe TBI. But most of the epileptologists or epilepsy doctors, would feel very, very reluctant to not put them on seizure medication because there is a focus that's sitting there. So an abnormal neuroimaging, abnormal EEG, or if you have any three of these etiologies as the cause of unprovoked seizure, uh, even after one unprovoked seizure, you should consider them epileptic because they have a very high risk of recurrence, which it would be otherwise true for patients after, two unprovoked seizures if they did not have any of these. So one thing I also want to clarify is with these three conditions, okay, sometimes we tend to see when the seizure happens. So if it happens within 7 days of insult or after 7 days of insult. So for example, patient had a CNS infection but had a seizure in the first week. The risk of recurrence in that case may not be as high as if it were to happen after 7 days. Um, so we tend to call this acute symptomatic seizure if it happens within the first week, and if it happens after first week, we call it remote symptomatic seizure. That's the terminology that's used, and it turns out that what I mentioned in this definition is this part. So if the seizure occurs after 7 days of insult, the risk of recurrence is very high and they will be considered epileptic. Now, don't get me wrong, within the first 7 days of this insult, if patients have seizures, then you will still treat them with anti-seizure medication, but they may not necessarily develop epilepsy down the line. In other words, they may not keep having seizures, for a long period of time. And usually, um, they may be able to come off of seizure medications sooner if they don't have recurrent seizures down the line compared to this group. So I think that's an important point to remember. So that is the definition of epilepsy and the difference between seizures and epilepsy. You can have 100 seizures in your life, but every time you have a seizure, your blood glucose was, let's say, for example, 30, and EEGs and MRIs are usually normal. That does not make you epileptic. In other words, this also implies that any new patient who comes in with a new onset seizure, they at least need some basic workup, CBC, CMP, drug screen, and a careful review of their medication changes. And if everything is negative, then ideally you should try to get a 20-minute EEG, at least in the hospital. I'll come to the yield of the EEG in a bit, and then some sort of neuroimaging, preferably an MRI, but at least a CT scan if you cannot do an MRI. Okay. We'll talk about the classification of seizures. Seizures have been classified in so many different ways over past 2-3 decades, and as our understanding has evolved, so has the classification. And I seriously do not think that the classification which I'm going to teach you, which is the most updated classification of seizures, is going to be a permanent or a long-term classification, because as I said, with more understanding, um, this is going to evolve. Perhaps out of all the classification, this is the one that makes most sense and it's most logical. So the older terms such as grand mal seizures, petite mal seizures, simple partial seizures, complex partial seizures, those terms have been abandoned. Nobody uses them. You will see sometimes even many general neurologists still using those terms, but we do not. But they no longer exist in the current classification system. In fact, the classification system has been made very simple. So seizures are broadly classified, or even epilepsies are broadly classified into focal seizures, generalized seizures, and then unknown. And so what is the primary difference between focal seizures and generalized seizures? It's the onset. When you say the seizure is focal in onset, you are implying that the seizure is starting in a specific part of the brain or one part of the brain. Let's assume that it is temporal lobe. And let's assume that in the temporal lobe, it's in the hippocampus. Hippocampus is the most epileptogenic tissue in the brain. So anyways, but when seizure starts in the hippocampus, and let's say then spreads to the rest of the temporal lobe, and then let's say it spreads to the same hemisphere, then you call it a focal seizure because it's starting at one point in the brain. Whereas generalized seizures, your whole brain basically fires synchronously, simultaneously at the same time. That is the basic difference. Now, this concept is recently being debated, or because there are some studies that say that even generalized seizures may have a very, very focal onset, but it rapidly involves bilateral network. But you don't need to know that. I mean, just understand that generalized, the main difference is the whole brain produces abnormal discharges simultaneously at the same time, whereas with focal seizures, the seizures start in one part of the brain and it may stay there or it may spread. So that's the basic difference. It's the onset. And why do we worry about that? Well, because the prognosis and the treatment options are actually very, very different between the two types. So let's study how you can differentiate this clinically. clinical differentiation. Okay, I mean, you can of course do an MRI. If MRI shows a tumor somewhere, you know it was a focal seizure. You can even differentiate them based on EEG, but we're going to focus on clinical differentiation. uh, Focal seizures, because it starts in one part of the brain, sometimes they may produce what's called auras in the beginning. Sometimes, let's say for example, if the seizure starts in sensory cortex or somatosensory cortex, then patients may experience tingling or paresthesias on the opposite side of the body. Okay, patients, if it starts in, for example, the visual cortex or occipital lobe, they may have visual auras. If it starts in the auditory cortex, they may have auditory auras. Temporal lobe auras usually can be very, very, like different and diverse, but I'm going to just mention some common ones, like olfactory aura, abnormal smell; gustatory aura, abnormal taste in the mouth; psychic auras. For example, a feeling of deja vu or severe anxiety, maybe even panic attack. Psychic auras. Autonomic auras, where they may have pupillary changes or tachycardia, rarely bradycardia, piloerection, their hair literally stands up before the seizure, things like that. Sweating, their skin becoming pale. These are all autonomic auras. Now, provided that patient just has one focus in the brain, you would expect that seizures will usually start in that very same location every time. In other words, the seizures, I think this is a line that you should remember probably for the rest of your life, is that seizures are stereotypical. Same thing over and over again, especially true with focal seizures, and even generalized seizures. But because you expect that if there is just one focus in the brain, it will start in the same part of the brain every time, and hence they're usually stereotypical. Same thing over and over again. If they have two focus, let's say left temporal and right temporal, the auras are still consistent. For example, left temporal lobe seizures will usually always produce one specific aura, and the right temporal lobe will always produce usually one specific aura if they are different. So they are still stereotypical. So auras are very important differentiating features between the two, usually. Second one is, I'm going to talk about the tonic-clonic phase. Tonic-clonic phase, okay? So tonic meaning the body becomes rigid. The body becomes rigid or stiff. That's tonic phase. And this is the time when you will hear them producing ictal cry, or like a sound during the seizure, like a brief ah sound. That happens during the tonic phase because your vocal cords are also going into the tonic spasm. And then clonic phase is what we call in layman terms shaking. Shaking is the clonic phase. So let's say you walked into a patient having a seizure in the hospital, and in the middle of the tonic-clonic phase, then there are some things you can pay attention to tell you if the seizure was focal. So some common features are focal onset. For example, focal onset of either tonic or clonic phase. So let's say left arm became rigid first before the right arm, then the seizure started over the right hemisphere because the left arm became rigid first. So it's the opposite side, right? Or if the patient started shaking on one side before the other, then again the seizure onset is contralateral. I mean, so if the patient started shaking the left arm first, the seizure onset was over the right hemisphere. So focal onset of these movements. Eventually they may become bilateral, but if it started on one side first, it's probably focal in onset. Then there is something called automatisms. which are basically semi-purposeful movements. And this can be oral automatisms or it can be limb automatisms. So oral usually is lip smacking or chewing movements, even though they are not eating. And then limb movements can be anything, yeah, semi-purposeful movements. For example, usually it is like fumbling around with near, you know, they have a phone in their hand and they just start fumbling, or they try to grab blanket repeatedly. So they look like semi-purposeful movements. That usually indicates involvement of perhaps basal ganglia and some other circuitry, with very focal onset, if you see that. The third one is what's called a figure of four posture. So when they have the tonic phase, during the tonic phase, one arm is extended out and the other arm is flexed at the elbow. So they literally make a figure of four. Uh, so this is an extended arm and this is an arm that is bent at the elbow. That's how they look like. So seizure onset is contralateral, usually, to the extended arm. To the extended arm. Next one is a fencing posture. Like, you know how those fighters hold a fencing posture? Again, one arm is extended or stretched out. This is the best I can draw, okay? And the other arm is flexed like this. So a fencing posture. Again, seizure onset is contralateral to the extended arm. This is very rare, fencing posture. Figure of four is much more common. Head or gaze deviation to one side. Head or gaze deviation. So if the head or gaze deviation is to the right side, then seizure onset is contralateral. It's probably over the left hemisphere. So you walk into a patient having a tonic-clonic seizure, pay attention to these things, because, you know, we'll come to like what causes generalized seizures, and then the question always is, okay, if it's an alcohol withdrawal seizure or if it's a provoked seizure, you usually should not expect this focal feature. So this is very important to know. So the tonic-clonic phase, and then in the post-ictal phase, post-ictal meaning immediately after the seizure, like any patient who have focal seizures or generalized seizures, they all will be confused, they all will be tired, they all will be sleepy. So those things do not help. But what helps you, let's say you walked into the room, the seizure is already over, but then there are still some things you can pay attention to in the immediate post-ictal phase that will tell you if the seizure was focal in onset. Aphasia, for example. Patient starts waking up, patient starts becoming alert, but patient cannot speak. He is aphasic, he or she is aphasic. Then the seizure onset usually is over the dominant hemisphere, which is usually left hemisphere in most patients. Then unilateral headache. This is actually ipsilateral in onset, one side. I mean, the same side. If they have a holocephalic headache, meaning entire head is hurting, that doesn't help. But let's say after every seizure, it's always the right side that hurts, the seizure onset was probably over the right hemisphere. Todd's paralysis. This is basically just a focal weakness after the seizure. Okay, Todd's paralysis. Patient has a seizure, they become weak on the right side, then seizure onset was over the left hemisphere, contralateral. Many times these get misdiagnosed as TIAs because by definition, Todd's paralysis resolve in 24 hours if there are no further ongoing seizures. So let's say if the seizure was unwitnessed. For example, 74-year-old man living with his son goes to work at noon, comes back at 4 p.m., patient has a first time unwitnessed seizure at 3:15 p.m. Patient himself does not remember the seizure. He thought he went to take a nap and woke up. Son comes in 45 minutes later and now notices right-sided weakness. Patient is back to baseline otherwise. They go to ER, they do the workup, and patient gets admitted. Patient gets MRI, MRI is normal. and um, they get diagnosed as TIA because MRI is normal. And given the age and other things, we often think, okay, stroke is probably, or TIA was probably the most likely thing, and the symptoms reversed. If they keep having TIAs despite optimal management, consider Todd's paralysis in the differential. This usually becomes a problem when the seizure was unwitnessed. And nose wipe. Once the seizure is over, if they wipe their nose with, for example, the right hand or the right index finger, it's again ipsilateral. The seizure onset was over the right hemisphere. I think in this phase, tonic-clonic phase, I'll add one more thing. It's the last clonic jerk. For example, if patient was having shaking bilaterally, which looks mostly symmetric, however, the last few jerking movements are only in the right side, only on the right side or right upper extremity, but the left upper extremity stops, then that is usually ipsilateral. Why is it ipsilateral? Because the side that starts first presumably also stops first. So for example, right hemisphere starts having seizure, then you would expect, some initial movements in the left upper extremity or jerking movements. Let's say nobody paid attention to it, the seizure became bilateral, now it's symmetric. Then the right hemisphere stops first because that's where the seizure started, but the left hemisphere still keeps going for a few seconds. And so the opposite extremity is still jerking. In other words, if you see the last few chronic jerks in the right upper extremity, the seizure onset was on the same side. Any questions? Otherwise, I'm going to delete this. I hope everybody's taking notes. If not, just come back to this video. Um, but I think taking notes is still useful, especially if you want to revise these things quickly. You are not going to have time to watch 1 hour videos for each topic the day before your exam. Okay, so focal seizures. These are clinical features, okay, of focal seizures. Sometimes you just don't know. Patients don't have the history. You can't get any reliable history from the witnesses, especially if they're witnessing it for the first time. It's too scary for them. And you can then use MRI and EEG, but sometimes they may not help. So you can use MRI and EEG to help classify patients in focal or generalized category if the clinical information is not sufficient. One thing I want to mention is, so the focal seizures can stay focal, but then, many times they spread to both the hemispheres. They spread to both the hemispheres. So for example, seizure started in the right temporal lobe, then the entire right hemisphere gets involved. That's the time that patient will usually lose awareness. And if the seizure now also involves the left hemisphere, they will usually lose consciousness and they will usually have tonic-clonic movements. So in that case, the term, that was previously used, I'm glad they got rid of it, is, focal to secondary generalized. I mean, but however, now we don't use those terminologies. We usually say focal to bilateral, tonic clonic. That's how we word it. That's how we word it. Okay. Uh, because if you say focal to generalized, you are actually, as I said at the very beginning, that the main differentiating feature is the onset. So when you're saying focal, you are actually implying it is focal in onset and it's not generalized in onset. So, it is almost counterintuitive to say that focal seizure became a generalized seizure. No, because the onset was not generalized. It was still a focal seizure at the onset. So you still use that word focal, but if it spreads to both the hemisphere, you then say focal to bilateral tonic-clonic, not focal to generalized tonic-clonic. So remember that in the new classification. I hope this clarifies your doubts. If not, then just stop me here, okay? If it is confusing. Because the main differentiating feature is the actual onset. And when the seizure is focal, you still use the word focal, but then do not say it's generalized because the onset was not generalized. So you say focal to bilateral tonic-clonic. if it was a tonic-clonic seizure. Now, many patients with focal seizures will not have tonic-clonic movements. For example, seizure just stays in the one hemisphere. They will lose awareness for a few minutes, or they may stare off into the space and the seizure is over. So in that case, we call it focal, usually because patients will lose awareness, focal unaware seizure. Focal unaware seizure. Very, very, very easy actually, or simple terminology, instead of using complex partial or simple partial, things like that. If the patient has preserved awareness, we just had a patient a few weeks ago when I was on call, I think it was a residency service patient. This patient would just have brief right-sided jerks or like tonic movements or stiffening, and he would not lose awareness. He would still have a conversation with you. In that case, you would just call it a focal aware seizure when the patient is not losing awareness. Previously, these used to be called simple partial, and previously these used to be called complex partial. And the only difference between simple partial and complex partial was the modifier was loss of awareness. To me, which makes no sense at all, because just because they're losing awareness does not necessarily make it complex. So that patient, I don't know who was a resident at that time on service. That patient, you know, was having them so frequently initially, at least, that would affect his ability to walk and result in falls and result in bleeds and other injuries, compared to a patient who is, for example, losing awareness with a seizure, but the seizure frequency is like once every 5-6 years. Right, so simple partial may not always be simple, so to say, and complex partial may not always be complex. The only modifier was loss of awareness. So in the new classification, they just call it the way it is: focal unaware seizure and focal aware seizure. If it becomes tonic-clonic, you call it focal to bilateral tonic-clonic. Generalized seizures, just remember this: generalized seizures usually, I like to think of it this way, usually result from provoked causes, although not always, but usually provoked causes will result in a generalized seizure. uh, with some exceptions, hypoglycemia, hyperglycemia may result in focal seizures. However, usually most of the generalized seizures, most of the provoked seizures are generalized. So for example, patient comes in with alcohol withdrawal, you would expect them to have a generalized seizure, meaning they should not have any preceding auras. In the tonic-clonic phase, they should not have any focal features. They usually, both the sides just stiffen up simultaneously. They usually have bilateral clonic movements, eyes roll back into the head. They don't look towards one side or the other. And then the seizure is over. They may be confused, sleepy, but they should not have any post-ictal focal features. Hypoglycemia, hyperglycemia are usually an exception. So that is why knowing those clinical features of focal seizures is important, because now if an alcohol withdrawal seizure patient, for example, has focal features, let's say he experienced an aura and his head was turned to one side, his gaze was turned to one side, and now he has a torts paralysis, then you need to take it with a grain of salt. You may not necessarily want to label them as just alcohol provoked seizure and not put them on any anti-seizure medication, because it had some focal features to it. Perhaps patient has focal epilepsy and alcohol withdrawal or alcohol consumption just reduced his seizure threshold. So I would usually take that with a grain of salt, and that's why knowing those focal features is very useful, or even paying attention to them is very useful, especially if you're a night resident. And the seizure happens, and next morning we are trying to gather this history, and usually the only thing we find is patient had a seizure. That's it. Doesn't mention anything else. So try to pay attention to those things if you can. It helps in managing those patients. Sorry. So provoked seizures are usually generalized with some exceptions, and then the other time when this generalized seizure will occur is what's called genetic generalized epilepsies. Genetic generalized epilepsies, there are a lot of them. I'm only going to focus on 2 or 3 most common ones that you need to know from internal medicine standpoint, or what perhaps they'll test you on your boards. Genetic generalized epilepsy. So these are epilepsies, remember, meaning they have recurrent unprovoked seizures. Can Are generalized and provoke seizures, not epilepsy, provoke seizures are generalized. So the two most common ones that they'll test you on are childhood absence epilepsy, or CAE, and then juvenile myoclonic epilepsy, or JME. The most important question in these people, as the name suggests, is age of onset, which is typically 4 to 11 years of age in childhood absence epilepsy for most of the patients. Everything I'm teaching is, I use these words a lot, usual, most commonly. It's because this is most common. There are always outliers. And with juvenile myoclonic epilepsy, usually 11 to 20, 21 years of age, but I have diagnosed patients in their 30s with JME. So as I said, this is usually the most common age range. So as the name suggests, and now this is again an important discussion, and some things that I want to clarify, is that these patients have what's called absence seizures, okay? Absence seizures. Whereas these patients with JME, they may have commonly myoclonic jerks. They may also have absence seizures, and they may have generalized. It's okay to use the word generalized here because it's a generalized form of epilepsy. Generalized tonic-clonic seizure. Generalized tonic. So usually they have multiple seizure types. Now, let's talk about absence seizures a little bit. So we are going to divert and we'll come back to these syndromes. When you say absence or absence seizure, this word absence is literally picked up from childhood absence epilepsy. Okay, so when you are using the word absence for these types of epilepsies, you're usually implying that patient is staring off into the space, or patient stops doing whatever she or he is doing and has what we call, or in other words, behavioral arrest. They just stop knowing what they are doing, and we call that behavioral arrest, or they may just stare off into the space. So that's an absence seizure. Now, the problem is that staring off or staring episode or behavioral arrest may also occur in focal seizure, usually temporal lobe seizures, okay? So this is a side discussion, or it can occur in absence seizure. Absence seizure means what? That what absence comes from where? Childhood absence epilepsy. So when you're using the word absence, what are you implying? It's a childhood absence epilepsy, but what are you also indirectly implying? That it's a generalized form of epilepsy. So I hope you are not getting confused here, because staring episode or behavioral arrest can happen with both generalized epilepsy, usually childhood absence epilepsy, but you can see that even JME patients have absence seizures, but they are both generalized epilepsies. However, they may also occur as part of focal epilepsies or temporal lobe seizures, the staring episode or behavioral arrest. So that is, clinically, we are just going to try to learn the clinical differences of the staring episode or of the seizure itself between focal and absence seizures. So typically, these are less frequent, whereas kid with absence epilepsy will usually have these multiple times a day. Like for example, sometimes even 10 to hundreds per day. Whereas this is so variable. Some patients may have it once every few years. Some patients may have a cluster, like 3, 4, 5 of them, but it's rare for somebody to have 100 focal seizures in a day. In at least I have not seen it. I'm an epileptologist. I have not seen it to have 100 focal seizures a day. But yes, they definitely can have 100 absence seizures a day. Um, these are usually longer in duration, typically 30 seconds. It can be up to 3 minutes, 5 minutes. It can rarely be longer, but usually that's a typical duration. These are usually very brief. They may be as short as 3 seconds. And if they're in status, they may have it ongoing. But let's say if they are not in status epilepticus, they may have it for like maybe a minute at most, but usually 3 seconds to 1 minute. So they're very brief. Usually, these may be associated with other focal features like automatisms and things like that. These do not. However, another differentiating point is that they usually have a postictal phase where they are confused, they're sleepy. These kids usually have no postictal phase. So, for example, if the seizure is brief, only lasting 3 seconds, they will resume the activities that they were doing right from the point where they left it. So, if hypothetically, if a kid was, on a bicycle, and let's say did not fall, then after 3 seconds, the kid will start riding the bicycle again, or they'll pick up the conversation right at the point they left the conversation. Whereas these patients may be confused with focal seizure. So these are the main clinical differences between a staring episode or behavioral arrest of focal seizures versus an absence seizure, which is basically a generalized form of seizure. So that is why, I hate when ER physicians or somebody like in a 60-year-old patient will call me that, okay, patient was staring off into the space and was having an absence seizure. Do not use that word. Just a patient was staring off into the space. I'm concerned about a seizure. Because when you're using the word absence, you are implying so many things. You are implying that patient, literally, basically, that it's a generalized form of epilepsy, which is simply not true. So if you don't know it, just say patient was having a staring episode and concern for seizures, instead of just using the word absence. Because when you use the word absence, you are implying a generalized form of epilepsy. So I hope that clarifies some of the most common misconceptions, and we'll just resume this. So they have absence form of seizures in childhood absence epilepsy. These are basically, one thing I forgot to mention is that electroclinical diagnosis, meaning you need supportive EEG evidence usually to label them as these forms of epilepsies. So their EEG will usually show, and I'm talking about in between the seizures, I'm not implying the seizures, okay, in between the seizures, or we call them interictal, ictal meaning seizure, and interictal meaning in between the seizure. They will show what's called 3 hertz, and because it's a generalized form of epilepsy, 3 hertz generalized spike and wave discharges. Whereas these patients usually will demonstrate 4 to 6 hertz generalized spike or polyspike discharges. So what does this mean? Hertz meaning what? Hertz, going back to physics, per second, per second. So if this is 1 second duration, these two lines, 3 hertz spike, and there are 21 channels in EEG, okay? Let's say these are 21 channels or some of the channels. Then you will usually see a spike and a wave, a spike and a wave, a spike and a wave. But it is generalized, so you will usually see them in most of the channels. A wave, spike, and a wave. 3 hertz, because there are 3 spike and wave. Spike wave, spike wave, spike wave. 3 hertz, correct. So that's how your EEG typically will look like. Whereas in JME, they will usually have, if these are the channels, they will usually have 4 to 6 hertz, so they're usually faster. And they may have pike or polyspikes, meaning multiple spikes like this, and a wave, something like this. I'm not an artist, you can clearly say from these drawings, but this is how JME EEGs will look like, and you will see them in all the channels. Generalized, because they are generalized epilepsies. So you need this EEG to tell you for sure that you are dealing with one of these genetic syndromes, because these are usually genetic. Okay, so they are what? They are electroclinical diagnosis. Important word. Treatment usually is with ethosuximide. For childhood absence epilepsy, this is probably the only time you'll come across this drug. It's usually the drug of choice. Although you can use any broad spectrum anti-seizure medication, okay? And because these JME patients have multiple seizure types, ethosuximide, which works usually only for absence seizures, is not preferred. And hence, these are usually treated with broad spectrum anti-seizure medications, which we'll hopefully cover quickly in a bit. Prognosis for these patients usually is excellent. Majority of the patients, 90 to 95% of them, will outgrow these when they hit the puberty, whereas JME is typically a lifelong condition, although usually seizures are easy to control, however, not always. And then triggers. Well, this can be triggers for any types, but particularly these epilepsies are extremely sensitive to childhood absence epilepsy is very sensitive to hyperventilation. You can just ask the kid to work out in the clinic and you will induce a seizure, or ask them to blow a wheel or something like a toy, and you will see them having a seizure right in front of you. And juvenile myoclonic epilepsies are actually extremely sensitive to photic stimulation, so flashing lights, um, or alcohol consumption, or sleep deprivation. Okay. Um, JME patients many times, like I've seen at least few of them here in last 3 years. They actually start out with myoclonic jerks in their teenage years and they never seek medical attention. Like they have this early morning, which is very typical, early morning myoclonic jerks. Myoclonic jerks are very, very brief jerks. Patients usually don't lose consciousness. However, they can affect it can affect their quality of life. If they have a brief jerk and they have a hot cup of coffee, they end up spilling coffee, over their skin, which may result in burns or other types of injuries. But they don't lose usually consciousness. They're very, very brief jerk. Basically, myoclonic jerks are the fastest movement you can imagine of a particular muscle. So imagine biceps, for example, flexion at the elbow. Try doing it the fastest you can, and that's a myoclonic jerk. That's how you should think of them. Anyways, so patients have myoclonic jerks, for example, and then let's say this kid decides, like, he's 25, she's 25, and they go to college and they're no longer with their parents. And in the college first year, they're like, okay, let's just go have some fun. So they go to a nightclub, they stay up till late, they drink some alcohol, they dance on the dance floor, they have all these classic triggers, and 10 years later, they will have their first generalized tonic-clonic seizure in setting of all these triggers. And up until now, they may not have had it. They were probably only having myoclonic jerks, which they never, sought medical attention for. And so now, if you're seeing this patient for the first time, you think, oh, 25, 26 years, generalized tonic-clonic seizure, new onset seizure. Well, outside of typical range of JME, it's not JME. Well, that's not true, because if you dig into the history a little bit more, and you ask them, they probably were having myoclonic jerks for past 10 years. I've seen at least 2 or 3 patients like these here. Um, and hence they get diagnosed sometimes even at a later age. So I hope this is clear, the generalized genetic generalized epilepsies and when you see them. And then talking about the broad spectrum drugs, which is a treatment for these 2 generalized epilepsy syndromes. Just move on to the drug part real quick. I'm not going to mention all the side effects of these medications. It's probably beyond the scope of this lecture. I would just recommend, reading them up on the books or maybe in your fancy apps that you guys use nowadays. Not that I'm old, but just review them somewhere. Basically, the side effects, because I don't think I can cover them in this lecture. But I'll just mention the broad spectrum drugs and the narrow spectrum drugs and why you need to know them. Okay. So broad spectrum anti-seizure medications, then narrow spectrum. Broad spectrum anti-seizure medications are those that work both for focal and generalized epilepsies, whereas narrow spectrum are those that usually work only for focal epilepsies. In fact, some of the narrow spectrum will make generalized epilepsies worse. So I'm going to name some drugs here in this group. Levetiracetam is a broad spectrum drug, or Keppra. Everybody, Keppra is the Tylenol of the seizure world, okay? Um, Levetiracetam is one. The newer version is brivaracetam, with less mood problems as a side effect. Valproic acid is a broad spectrum drug. Lamotrigine is a broad spectrum drug. Topiramate, also used very commonly for migraines. Zonisamide and perampanel. These are typically considered broad spectrum drugs. Whereas your all the P's, phenobarbital, primidone, phenytoin, they're considered narrow spectrum usually, although I've seen some patients with generalized epilepsies being treated with phenytoin, and it actually works, although I do not know there is a lot of evidence for it. Carbamazepine and some of its newer derivatives such as oxcarbazepine, which is trileptal, eslicarbazepine, Aptium, your gabapentin and pregabalin. Lyrica, basically. Gabapentin is Neurontin. Lacosamide or Vimpat, my favorite drug. Clobazam or Onfi typically are considered narrow spectrum drugs. Sometimes the simplest thing I have had to do is PCPs usually will just put some patients, for example, a 26-year-old woman that I saw with a generalized tonic-clonic seizure. EEG previously had shown 3 Hz generalized spike in wave discharges. However, PCP put the patient on carbamazepine before she could come see me, and seizures actually got worse because some of the narrow spectrum would make generalized epilepsies worse. The simplest thing I had to do was to just switch her from carbamazepine to levetiracetam, and she became seizure free. So if you don't know if patient has a focal or generalized seizure, just use a broad spectrum drug which will work for both. That's the summary of this. Uh, Last thing that I want to cover is when should I order a 20-minute EEG? And our 20-minute EEG is useful. So patient, let's say for example, gets, usually ideally if a patient is back to baseline, they should, for a new onset seizure, they usually do not need to be admitted from the ER. But let's say a patient gets admitted for other medical reasons and patient had a new onset seizure, a 20-minute EEG is still a reasonable test, and you should try to get it in the hospital. But usually you should try to do it within 24 hours of seizure, because the yield, even if you do it within 24 hours, is roughly about 30%. But after 24 hours, the yield goes down to like less than 20%. Okay, so it's not really very useful after that. And some sort of neuroimaging you should try to get, preferably an MRI, but CT head at least for these patients. Of course, a long-term EEG is very useful to capture those discharges, but they are not cost-effective, at least for a new onset seizure patient, at least in the hospital. You can do them on an outpatient basis, but may not be very reliable in the hospital. So yeah, that's basically the seizures, except I think the side effect profile of the seizure medication, which probably you can find it anywhere, in this age and time. And then I think one topic that I did not discuss today was status epilepticus, which I'll probably try to cover some other time. Does anyone have any questions?
Doesn't look like there's any questions, Dr. Doshi.
Sounds good. Okay. Thank you so much.
Thank you.
Bye.